Welcome to MediCrush, where I help you crush your medical examinations. In this video, we will be covering bacterial meningitis. Bacterial meningitis is infection of the meninges, the protective covering of the brain, which includes the dura mater, arachnoid, and the pia mater. This infection results in inflammation that results in meningitis. In terms of the bacteriology of meningitis, in neonates and children less than 2 months of age, group B Streptococcus is the most common bacteria. In older children and teens around 10 to 19 years of age, Neisseria meningitidis is the most common bacteria. In all other age groups, strep pneumo is the most common bacteria. In terms of strep pneumo, that's the most common cause in adults of all ages, including the elderly and children between 3 months and 10 years of age. It is the second most common cause in older children. An important gram stain for strep pneumo that you should definitely know for examinations is gram-positive cocci in pairs. They write that in the question, this answer they're looking for is strep pneumo. Neisseria meningitidis is the most common cause in older children and teens between the ages of 10 to 19 years of age. It is also the second most common cause in adults after strep pneumo. A key feature, no matter how old the person is if you see a petechial or purpuric rash, that is specific for meningococcemia, you should be worried about Neisseria meningitidis. Now, a classic gram stain for Neisseria meningitidis is gram-negative cocci in pairs. Some other very important complications of Neisseria infections is that patients may develop septic shock, they can develop disseminated intravascular coagulation, or DIC for short, which is why they develop the classic purpuric rash, and they can also develop adrenal hemorrhaging that results in an adrenal crisis within 12 to 24 hours of presentation. If they develop an adrenal crisis due to adrenal hemorrhaging, we call that Waterhouse-Friderichsen syndrome. Listeria monocytogenes is not a most common organism. However, it is seen with increased incidence in certain populations, specifically neonates less than 1 month of age, anyone over the age of 50 with meningitis, patients that are immunocompromised, and that may include steroid use, that can include malignancy, chemotherapy, that can include immunosuppressant use of medications, or even someone that is post-transplant. Or also pregnancy has an increased risk for Listeria monocytogenes as well. Group B strep is a key feature in neonates less than 1 month of age and infants less than 3 months. And that is because group B strep, also known as Streptococcus agalactiae, colonizes the vaginal tract, and so therefore it can be transmitted to the fetus during delivery. That is why we also screen women in the 3rd trimester for GBS. And if they're positive for GBS, we often treat them with antibiotics such as ampicillin. In neonatal meningitis, we said earlier that group B strep, also known as Strep agalactiae, is the most common bacteria. E. coli is the second most common cause. Other bacteria we worry about could be other gram-negative rods and Listeria monocytogenes. Haemophilus influenza used to be a big problem, but with the widespread vaccination of Haemophilus influenza vaccine, that has resulted in a dramatic decrease in causes of H. flu in pediatric meningitis. However, in unvaccinated children, it still plays a big role in those infections. In nosocomial infections, it could be strep pneumo from CSF leaks, it could be Staph aureus or Staph epidermidis, especially with head trauma or neurosurgery, as it can get access to the skin during surgery, or other gram-negative bacilli. In terms of the pathophysiology, what happens is that one of the ways you can acquire meningitis is via hematogenous spread. If someone develops bacteremia or bacteria in the blood, that bacteria can gain access across the blood-brain barrier, resulting in meningitis, especially Neisseria and Streptococcus pneumoniae. The other way you can acquire meningitis is via direct extension. So for patients that may have otitis media or sinusitis, that could result in direct extension into the central nervous system. As a matter of fact, about 25% of patients may have a recent history of either otitis or sinusitis in their history. Manipulation of the meninges during neurosurgical procedures may also result in acquiring bacterial meningitis. Now, there are two components that can cause meningitis. You need to have virulence factors for the pathogens that allows them to bypass the host's natural defense systems. Or you can also have as well, in addition to that, the host immune response. As a matter of fact, we believe that just as the bacteria itself plays a role in causing damage, the host immune response actually causes a good significant amount of damage. And that's because in response to the infection, what happens is the body produces inflammatory cytokines and inflammatory changes such as increased permeability, which can also increase the risk of damage to the brain. That can result in increased intracranial pressure and a lot of the symptoms we see with meningitis, such as fever, headaches, and altered mental status changes. This also explains why, for some patients, we often give them glucocorticoids as part of the management. But Dwayne, this is a raging infection in the brain. Why would you give steroids to suppress the immune system? Again, the idea is that the immune host response causes a lot of the damage in addition to the bacteria. So we give the antibiotics to take care of the bacteria, and the steroids can be used to decrease the host response to the infection. And again, this host response can increase the permeability of the blood-brain barrier, which also worsens the damage as well as bacterial entry into the meninges. Now, the classic presentation of bacterial meningitis is going to be fevers, nuchal rigidity or neck stiffness, and altered mental status changes. That's the classic triad for meningitis. Many of these patients often also have a headache that may be severe. As a matter of fact, most patients have at least 2 of those 4 classic symptoms. In addition, they may have photophobia from meningeal irritation, phonophobia, chills, nausea, and vomiting. Less common features of bacterial meningitis include new psychiatric changes and neurological deficits. If those are present, then it more likely leans to encephalitis as a cause. And if it's not encephalitis, it could be a combination of both meningitis and encephalitis that is known as meningoencephalitis. So that could be another cause of neurological symptoms and new psychiatric symptoms is either encephalitis or meningoencephalitis. On physical examination, look for nuchal rigidity or neck stiffness. The patient may not be able to touch the chin to the chest, for example. They can have a positive Brudzinski sign whenever you try to passively flex the neck. That can result in either involuntary knee or hip flexion, or they may have a positive Kernig sign. And that's where when you extend the knee and the hip is flexed at 90 degrees, that can result in either inability to do so, resistance, or pain. On examination, you may also see purpura fulminans. Again, if you see that classic petechial purpuric or ecchymotic rash, that highly suggests meningococcal infection. You get gram-negative sepsis and DIC that results in bleeding, resulting in the classic purpuric rash. The most important test when meningitis is suspected is a lumbar puncture with analysis of the cerebrospinal fluid. Now, that is the most important test, and that is usually performed prior to initiating antibiotics if it can be done promptly. The classic findings for bacterial meningitis include a decreased CSF glucose, and that's because the bacteria will consume the glucose for energy, resulting in a decreased CSF glucose. Also, we fight off bacterial infections with neutrophils, so the neutrophil count will be higher than normal in the CSF fluid analysis and also part of the increased cell count. They can have an increased protein and opening pressure, but that's non-specific. Neuroimaging is not usually needed to make the diagnosis of bacterial meningitis. The LP is the most important test. However, if someone has either signs or symptoms of a mass effect or increased intracranial pressure, then we often want to perform some kind of neuroimaging before doing the LP to prevent uncal herniation. So in patients that have papilledema, for example, focal neurological deficits, focal new onset seizures, or severe altered mental status changes, you may want to consider doing imaging prior to LP. Also, if they're one of those immunocompromised states or have a history of CNS disease, you may also want to consider doing neuroimaging before performing the LP. If you decide to delay the imaging, you should do blood cultures, antibiotics, imaging, and then LP. The laboratory findings that are important are going to be getting the blood cultures to look for the classic bacteria that are causing the meningitis as well. In addition, look at the gram stain. If you see gram-positive cocci in pairs, that is hallmark for Streptococcus pneumoniae. If you see gram-negative cocci in pairs, that is hallmark for Neisseria meningitidis. If you see gram-positive bacilli, that is hallmark for Listeria monocytogenes. If you see gram-positive cocci in chains, that is going to be hallmark for group B strep, also known as Streptococcus agalactiae. If you see gram-negative rods, you can think of organisms such as E. coli and Klebsiella. Other laboratory findings that are supportive are an increased C-reactive protein. Remember that CRP is a non-specific marker of inflammation. In patients that have an increased procalcitonin level, that also suggests a bacterial rather than a viral cause for meningitis. CBC may show a high white count, but they may also have leukopenia, so therefore it doesn't help you as much, but we often obtain it anyway. In terms of the management of meningitis, you want to start antibiotics along with dexamethasone if indicated as soon as possible after obtaining blood cultures. So in someone where you can get a prompt lumbar puncture, you get a lumbar puncture, blood cultures, then antibiotics should be started. If there's any reason why you have to delay the lumbar puncture, so if it's delayed or deferred for whatever reason, for example, having to get neuroimaging prior to LP, then the answer should be blood cultures, antibiotics, neuroimaging, and then LP in that specific order. Again, the key is that you want to start antibiotics as soon as possible. Delay of antibiotics can cause a rapid increase in the mortality of the patients. The longer you wait, the higher the mortality. In terms of dexamethasone, we can use dexamethasone in children greater than 1 month of age and adults. The idea is that we said before, the host immune inflammatory response causes a lot of the damage that occurs with meningitis, resulting in certain neurological sequelae, such as cranial nerve 8 related hearing loss, cognitive defects, motor instability, and mortality issues. And so therefore, especially with strep pneumo, so we often will give them corticosteroids in these patients to help reduce the risk of these neurological complications. In children, especially if you worry about H flu influenza for whatever reason, that has also been shown to be helpful as well to give steroids. However, we do not use steroids in most neonates under the age of 1 month. In terms of antibiotics, if they're neonatal meningitis up to 1 month, the preferred regimen is going to be ampicillin plus either gentamicin or a third and or fourth generation cephalosporin. And that can include either cefotaxime, ceftazidime, or cefepime. Again, we do not use steroid therapy in neonatal meningitis. Now, the reason we use those specific antibiotics, the cephalosporins, we don't use ceftriaxone because in neonatal, the problem is that we worry about the liver being damaged from ceftriaxone. Now, for patients 1 month to 50 years of age, the preferred treatment is going to be vancomycin plus ceftriaxone. The vancomycin covers gram-positive MRSA, and the ceftriaxone and the other third or fourth generation cephalosporins have good gram-positive and negative coverage. And again, we often add dexamethasone to reduce the sequelae, especially if strep pneumo is suspected. If they're over the age of 50, they have debilitating disease or they're immunocompromised, then we're going to use vancomycin plus a third or fourth generation cephalosporin plus ampicillin. Now we add the ampicillin to cover for Listeria, both in neonatal meningitis as well as over the age of 50 and immunocompromised patients. And again, we give dexamethasone to reduce the sequelae. Once you get your cultures and sensitivities back, you can then tailor the antibiotic based upon the bacteria that is present. Last couple things is going to be, what if it's Neisseria meningitidis? Either you know it or suspect it based upon gram stains showing gram-negative cocci in pairs, or whatever reason, you want to make sure that you put the patient on droplet precautions and it's going to be continued for the first 24 hours after you initiate the antibiotics. Now, post-exposure prophylaxis for close contacts with either prolonged exposure for more than 8 hours or direct exposure to respiratory or oral secretions should receive prophylactic antibiotics. And this includes household contacts, roommates, romantic partners, for example. You have 3 options: rifampin, ceftriaxone, and ciprofloxacin. If they're pregnant, we prefer not to use rifampin and cipro, so in pregnant patients, we prefer ceftriaxone. The prognosis of bacterial meningitis depends on many factors, such as the age of the patient, their comorbidities, and how early you start the antibiotics. Delaying the antibiotic for any reason has been shown to increase mortality, which is why blood cultures antibiotics are so important in the management for meningitis. So now it's time to test your knowledge on what we just spoke about with some questions. In this section, you should pause the question to give yourself enough time to answer it, and then unpause the video and I'll walk you through the question so you can get into the mind of a test writer as opposed to just being a passive test taker. Which of the following is the most likely cause of her presentation? You have a 6-day-old neonate that presents with meningitis and they had spontaneous vaginal delivery, which means we worry about bacteria that she may have been exposed to during birth through the vaginal canal. Remember that group B strep, also known as Streptococcus agalactiae, it is the most common bacterial cause of neonatal meningitis, especially less than 1 month of age. E. coli is the second most common after Streptococcus agalactiae. Which of the following is more consistent with encephalitis as opposed to meningitis? Remember that the symptoms can overlap and one person can have either encephalitis, they can have meningitis, or they can have both, which is meningoencephalitis. But in terms of encephalitis specifically, the presence of focal deficits and new psychiatric symptoms are more consistent with either encephalitis or someone that has a combination of both meningitis and encephalitis. What is the most likely finding? In this case here, you have a 15-year-old boy that presents with symptoms of meningitis, but most importantly, they have the classic petechial, purpuric, and ecchymotic rash. That rash is going to be hallmark for meningococcemia, making the best answer here gram-negative cocci in pairs. No matter how old the patient is, if you see that classic rash, you want to be highly suspicious of Neisseria meningitidis. Plus, this kid also is in an age range where Neisseria is the most common, between the ages of 10 to 19 years of age. What is the best next step in the management? This patient presents with symptoms of meningitis and they have a positive Kernig sign, which means you want to do a lumbar puncture as soon as possible. That's the diagnostic test of choice for suspected bacterial meningitis. Whenever it can be performed promptly, we do that before initiating antibiotics for bacterial meningitis. If you have to delay the LP for whatever reason, then you do blood cultures, antibiotics, neuroimaging, and then LP. In this case, bacterial meningitis, bacteria love to eat glucose, and therefore you have a decreased CSF glucose is hallmark for bacterial meningitis. All the other parameters are expected to be increased in bacterial meningitis. This case, you have a patient that's over the age of 50, right, that has symptoms of bacterial meningitis. But the key about this is that in adults, including the elderly, the most common bacteria that we worry about is going to be Streptococcus pneumoniae. Now, remember that Listeria monocytogenes is seen with increased incidence, but it's not the most common. So clinically, you cover for Listeria with ampicillin, but strep pneumo is still the most common bacterial cause of meningitis of adults of all ages. What is the most appropriate management? 54-year-old male presents with symptoms that present similar to meningitis. They have the classic findings and they're over the age of 50, which means you want to treat them with vancomycin to cover for gram-positive MRSA, a third or fourth generation cephalosporin, in this case cefepime, and ampicillin to cover for Listeria in patients over the age of 50 with debilitating disease or if they are immunocompromised. In this case, you have a 20-year-old male that presents with gram-negative cocci in pairs, which is indicative that he probably has meningococcemia due to Neisseria meningitidis, and therefore his roommate, which is a close contact for more than 8 hours, should receive prophylaxis. The three options are ciprofloxacin, ceftriaxone, or in this case here, oral rifampin can be used for prophylaxis of close contacts or anyone with direct contact with either oral or respiratory secretions. In this case, having given the pneumococcal vaccination and the Hib vaccination has been shown to reduce the incidence of pediatric meningitis. So in this case, Haemophilus influenza vaccination has been shown to reduce the complications of pediatric meningitis. Which one is the empiric management of choice? In this case, you have a 10-year-old that has CSF findings that are consistent with bacterial meningitis, and the Gram-Stain is pending, so we're going to give them empiric treatment. So remember, 1 month to 50 years of age, the preferred treatment is going to be ceftriaxone, vancomycin, and also dexamethasone to reduce the neurological sequelae, especially with strep pneumo, and if we worry about H influenza. So I hope that you found this video helpful. If you did, please like, also comment, let me know which part of this video was helpful for you. Also, share with your friends. Sharing is caring. And last but not least, please subscribe to the video. That way you can be notified when new video drops. And once again, you crushed it.